Hello everyone, welcome to the first video of a series where I go over some NREMT practice problems. I am a nationally registered EMT. I've been through the whole process. I'm going to give you a little bit of insight on what to expect while taking the NREMT. For each video that I make going over the practice problems, I will also upload a video going more in depth with why the answers are what they are as a little bit more of an explanation. And yeah, let's get. So, the first question we have, a 25-year-old male was hit in the chest with a baseball. He is alert but complaining of difficulty breathing and chest pain. His pulse is 120 beats per minute, and his blood pressure is 90/60, and lung sounds are diminished on the right side. What is the most likely diagnosis? So, is it myocardial infarction? Is it tension pneumothorax, pericardial tamponade, or a rib fracture? So go ahead, try this on your own, and then I will go over the answer. So for this one, it is going to be tension pneumothorax. So myocardial infarction, we know that's a heart attack. And when we read over up top the question, we don't see anything that would indicate heart attack or indicate tissue death of the heart. Pericardial tamponade, that's going to be when there is pressure on the heart. And this could be true. The thing with pericardial tamponade is it's typically caused by a fluid buildup, which we don't really see in this question indicating it. Rib fracture is going to be very possible when you get hit with a baseball and can lead to tension pneumothorax. The reason why tension pneumothorax is the best answer is going to be because of this right up here. This blood pressure being low, that's what tells us it's tension pneumothorax, because tension pneumothorax is going to be pressure put on the lungs and, more importantly, the heart, which prevents it from refilling all the way. And this can be caused by a rib fracture, it could be caused by direct trauma. So that compressed heart is going to lower blood pressure, and to compensate, your body's going to increase the pulse. So we have this 120 pulse, which is a little bit high. So that's how we know that it's going to be tension pneumothorax. Okay, so let's go on to the next one. This is a cardiology and resuscitation question. You arrive to find a 50-year-old male, sorry about that, who collapsed suddenly. Bystanders are performing CPR. An AED is applied and shows a rhythm of ventricular fibrillation. What is your next step? So, let's take a look one by one. Take a second to answer this yourself. So, do we A, administer a dose of epinephrine, B, continue CPR for 2 minutes, C, deliver a shock with the AED, or D, check the pulse before shocking? So, this answer is going to be C. So, administering epinephrine, not typically done when with the heart rhythm given, which is ventricular fibrillation. Continue CPR for 2 minutes. There's really no reason to continue CPR for 2 minutes when we have the AED pads already applied. And when you apply an AED pad, if the rhythm is a shockable rhythm, which ventricular fibrillation is, the AED will tell you that a shock is advised, and it will tell you to deliver that shock, which is why we would deliver that shock right away. So you don't need to continue CPR. We know that it's a shockable rhythm. We know that we should shock. And then you wouldn't check for a pulse because it would be showing like up on the AED already, telling you what the rhythm is. We know what we're working with. We don't need to find a pulse or not. We would just shock for that. Moving on to the next one. A 45-year-old female presents with a severe allergic reaction after eating shellfish. She has hives, swelling of the face and lips, and is complaining of difficulty breathing. Her blood pressure is 90/50, and she has audible wheezing. What is the best initial intervention? And I'll let you read over this yourself. And of course, the right answer is going to be B. Administer epinephrine via auto injector. So let's go through each one. A. Administer 5 grams of oral glucose. Why would we give oral glucose to this patient? There's no signs of low blood sugar. Oral glucose is what we give to diabetic patients whose blood pressure is low. Um, Stuff that we would look for in a patient like that is, for starters, low blood sugar. You'd also expect to see altered mental status, ANO times 2, ANO times 1, certain stuff like that, maybe slurring of words, and just a visible look of disassociation. That's when we would give oral glucose. So, not during shellfish. Provide oxygen via a nasal cannula. Um, in the current state, uh, if we were to transport this patient, yeah, we might give them oxygen. But right now, the very first thing we would do is try to solve we have difficulty breathing, which is a main concern. We have low blood pressure, which is a main concern. And then hives and swelling are very common signs of an allergic reaction. Or would we assist with her prescribed antihistamine? So, antihistamines obviously combat allergies. However, antihistamines is going to be for minor allergic reactions. Given the hives, the swelling, the difficulty breathing, and the low blood pressure, these are signs of like anaphylactic shock. So it's not a minor reaction; it's a very major reaction. This is anaphylactic shock, and epinephrine, which is a vasoconstrictor, will reduce swelling, open up the airway, and increase that blood pressure, which counteracts all of the negative symptoms that this patient is experiencing. So we would give her auto injector. Depending on where you end up working as an EMT or what your protocol is, you may have auto injectors. I know my company does not. For my company, it's a vial and a syringe. You draw it up yourself. And we can go into doses later in the next video that I'll go over these questions more in depth. But keep in mind, depending on where you work, maybe you'll get an auto injector, which would make it easier. For me, for a lot of others, it's just a syringe. You have to draw it up yourself. Okay, going into an OB question. A 32-year-old woman is in her third trimester of pregnancy and complains of sudden severe abdominal pain and vaginal bleeding. She denies any trauma. What condition should you expect? Placenta previa, uterine rupture, ectopic pregnancy, or preeclampsia? So for this question, before I give the answer, take some time, try to get it yourself. It's going to be a uterine rupture, which is B. So let's go over why. So let's go through each one. Placenta previa is going to be a complication where the placenta covers the uterine opening, um, which, given the nature of our question, it doesn't appear like that's happening. We have no reason to suspect that. Uterine rupture makes the most sense because it's simply a tear in the uterus, which is now bleeding, which checks out with our question. Ectopic pregnancy is when the egg it inserts itself somewhere else, not in the uterus. Typically, this happens in the fallopian tubes. And the reason why we are pretty confident that this isn't the case is because bleeding is typically limited. On top of that, these are also usually diagnosed very early on, as early as the first trimester. As you can see, we are in the third trimester up here. So probably not ectopic pregnancy. And then for preeclampsia is going to be it's going to be like an increase in blood pressure, essentially, which isn't really something that's given to us in this question. Again, no reason to suspect that. The one that makes the most sense is going to be uterine rupture. Okay, for our next run, which is a pediatrics question, a 3-year-old child is unresponsive and cyanotic after choking on a small toy. You cannot hear any air movement and no chest rise is seen. What should be your first intervention? So, the correct answer for this is going to be the liver abdominal thrust. So, Let's go through each one once again. Perform chest compressions. Why? This patient's heart is still beating. We're assuming that there's no need to pump their heart for them if it's still pumping itself. Perform a blind finger sweep. This is no longer in protocol. It used to be. We don't do blind finger sweeps anymore. And very rarely do we ever stick a finger in the mouth. I think some protocols allow for a finger to be inserted into the mouth when you can see the object. I don't think that's in a lot of protocols, though. Could be wrong on that. But no, we don't want to perform a blind finger sweep ever. Attempt ventilations with a bag valve mask. No. Something's in the airway. This patient is choking. So all that ventilating is going to do with the BVM, that's just going to push the object further down. If anything, it's not even going to get any air into the child because his airway is blocked, right? So why are we doing that? Delivering abdominal thrust makes the most sense given the age, being 3, very young, very small. And given the fact that they're choking and they have an airway obstruction. So it would be 5 abdominal thrusts, and then you would follow that up with 5 back blows to try to clear that out. No chest compressions, heart is still beating, never do a blind finger sweep ever, and there's no reason to attempt ventilations, so B. Okay, a 70-year-old male with a history of COPD is experiencing difficulty breathing. He is sitting in the tripod position using accessory muscles to breathe, and his oxygen saturation is 85%. What is the most appropriate treatment? So, take your time, read through it. The correct answer is going to be B once again. Provide oxygen via a non-rebreather mask at 15 liters per minute. So, assist with ventilations using BVM. He's not really breathing well on his own already, so you would think help him out with ventilations. Given that he still is breathing, though, even though it's not well, he doesn't need us to ventilate for him. Administer O2 via nasal cannula at 2 liters per minute. So it's good that we're giving oxygen. That should be the first step in this scenario because we see his O2 saturation is 85%. However, 85% is really low. We're looking at the target range should be about 95 to 100%. When a patient is below 95%, that's when we start giving oxygen. 85% is far below that. 2 liters a minute just isn't enough. We want a higher flow oxygen. 15 liters per minute is a great amount. And then having the patient breathe into a paper bag. We don't carry paper bags on our trucks. And also, that wouldn't even really solve his low O2 saturation, which is the main concern here. So we would administer oxygen via a non-rebreather mask. And just as a little side note, with COPD patients, you do want to be cautious with administering oxygen. I'll talk about why in a later video, but one of the biggest reasons is you don't want to blunt their respiratory drive, and we'll get into all that. So just keep in mind, be cautious when giving O2 to COPD patients, but typically speaking, when your O2 saturation is that low, oxygen is always going to be like the first answer that you want to give. All right, number 7. A 30-year-old woman has been involved in a motor vehicle accident and presents with a rapid, weak pulse and cool, clammy skin. She has a penetrating wound to the abdomen. Her blood pressure is 80/40, and we want to figure out what type of shock is she most likely experiencing. So take your time, read through each answer carefully, read over the question. A lot of the NREMT is going to be reading and understanding the question. That's going to be how you get most of your answers, so read through it carefully. Okay, and this is going to be C, hypervolemic shock. And we'll talk about why right here. So, we're given a blood pressure, 80/40, which is very low. And then we're also given a penetrating wound to her abdomen, which means probably have some bleeding. So Hypovolemic shock is going to be shock brought on by a reduced volume in the vessels. This could be caused for a number of different reasons. For this particular reason, it's probably going to be because of blood loss, causing that low volume in the vessels. So going through each one, cardiogenic shock is going to be shock as a result of your heart's inability to pump blood out to the rest of the body. Given what we have up on the top of the question, there's not really any indication that the heart isn't pumping the way it should, other than a low blood pressure, but this would much be more representative of hypovolemic shock. Septic shock is going to be a systemic infection causing shock in the human body. Again, we don't have any signs of infection, and given that she was in a motor vehicle accident, doesn't really seem like that would cause infection right away. We don't have any irritation, any fever, anything like that. Neurogenic shock is shock as a result of the vessels losing their kind of like their firmness and their shape as a result of a neurological disorder, injury. Essentially, like, let's say if something happens to your spinal cord, your vessels start losing some of those tone, they start loosening up a bit, and you get a drop in volume, which is going to lead to shock. So hypovolemic shock makes the most sense because that is shock as a result of low blood volume, which, given up here our blood pressure, we can see that this might be the case. We have low blood pressure, we have low blood volume, we have hypovolemic shock. Okay, a 40-year-old construction worker falls from a ladder and is found lying on the ground unconscious. He has snoring respirations, and you notice an obvious deformity in his right leg. What is your first priority? So, again, read it carefully, go over it slowly, and then come to your answer. This one's going to be B. Open your airway using a jaw thrust maneuver. So, let's go through each one. Splint the leg. If he has a broken leg, yes, this would be something that you would have to do. It would not be priority. Assess for signs of spinal injury. This is the problem with the NREMT, is going to give you questions with kind of like multiple right answers. Yes, you should assess for signs of spinal cord injury. But this can kind of be done as you're running up, and it's going to be something that's assumed. So we're going to always assume for spinal cord injury when we have these traumas. Check the patient's blood pressure. No, because there's really no reason to in this scenario, especially if we don't see him bleeding. We're going to want to open that airway using the jaw thrust maneuver, and let's explain why here. So we see that he's unconscious, and we see that he has snoring respirations, which is an abnormal lung sound, which means he's not getting proper airway ventilation. So he's not getting in enough air into his body. So how do we fix that? We could fix that very simply by opening the airway, right? It seems kind of obvious, but sometimes the answer is obvious. Just open the airway. Now, why wouldn't we use the head tilt chin lift, which I'm sure most of you probably thought of as a potential option? You never use head tilt chin lift when we assume spinal cord injury, because we don't want to interfere with that neutral alignment of the spine. We don't want to move that spine in any way. So we're going to use a jaw thrust maneuver. And again, I'll talk about that in a different video. But because he falls from a ladder and is found unconscious, we're going to assume spinal cord injury. So we're not going to head tilt chin lift. We're going to jaw thrust, which is a safer maneuver that doesn't interfere with the position of the spine. A 65-year-old male complains of chest pain that radiates to his jaw and left arm. He is pale and diaphoretic. His pulse is 110. His blood pressure is 140/90. What is most likely the cause of his symptoms? So, read each symptom carefully, read each answer carefully, and then choose your answer. So, this is going to be myocardial infarction, letter C. So this is going to be another one of those questions that's a little bit tricky. So all four of these answers share a lot of the same symptoms that were given up top. All of them would have chest pain. We would expect to be diaphoretic in a lot of them. And we would expect similar pulses for a lot of these. So the sign in the question that eliminates 3 out of the 4 is going to be um, pain that radiates to his jaw and left arm. This is almost exclusively found in myocardial infarctions. They're not really found in aortic aneurysms or pulmonary embolisms or pericarditis. This is going to be a telltale sign of an MI. So whenever you see radiating pain to the left arm, think MI. That almost always gives it away. Okay, and for our last question, a 30-year-old diabetic male is found unresponsive with shallow respirations and a fruity odor on his breath. His skin is warm and dry. What is most likely the cause of his condition? So take your time, answer it by yourself, and we'll discuss. So this one is going to be B, hyperglycemia. So hypoglycemia is going to be low blood sugar, low sugar in the blood. Hyper is going to be the opposite. Hyperglycemia is going to be high blood sugar. The reason why it's not stroke, we're not really given any major stroke signs. We're not told about the gait. We're not told about facial droop or anything like that. For alcohol intoxication, you could get some of these symptoms with it, with alcohol intoxication, but the symptom that gives it away is going to be fruity odor on his breath, and this is a sign of diabetic. It's going to be a sign of diabetic ketoacidosis, which is essentially a condition common in patients with diabetes, and it's a buildup of, well, it's when your body breaks down fats at an excessive rate, and it builds up ketones, which accumulate in the bloodstream, and it gives off kind of this fruity smell, and it causes a raise in blood glucose. So this fruity odor on the breath, telltale sign of diabetic ketoacidosis, which is directly related to your blood sugar going up, hyperglycemia. So that's how he came to be. So that is going to be the end of this particular video. Keep your eyes out for a video released after this, which will have more in-depth explanations for all of the answers. And yeah, I'll see you on the next one.